welcome all of you. So, good afternoon, everyone, and welcome. First of all, thank you so much for joining us today, and it's really great to see so many of you here. My name is Daniela Quaggia. I work with Cittadinanza Attiva Active Citizenship Network, a European civic organization that works with patients and citizen groups to promote patients' rights and public participation in health. We are here today thanks to the Prophet Project. We will say more about it afterwards, in which we, as partners, contribute with the citizens and patient perspective, focusing on clear communication, trust, and equitable access to innovation. The Catholic University of the Sacred Heart, with us in this webinar, is the project coordinator. Today's online informative session has a simple goal to try to understand together in a clear language. There is someone entering. In a clear language, what personalized prevention means, how it can work in real life, and why it matters for citizens, patients, and families. And we will do it thanks to Sara Farina and Tamara Milagre. I will introduce them afterwards, but thank you in advance for your time. Why do we mention right to innovation in the title? Because from our perspective, health innovation should not remain something for a few people or a few places. It should become something that is accessible, understandable, and useful for everyone. Something that can truly be considered a right. This connects to something very important for Cittadinanza Attiva and most of you here today, the European Charter of Patients' Rights. Already 25 years ago, it included the right to personalized treatment, stating that every person has the right to diagnostic and therapeutic programs as adapted as possible to their personal needs. Today, that same idea is increasingly reaching prevention, how we try to avoid disease or detect it earlier and manage risk better. So, what do we mean by personalized prevention? As our wonderful speakers after me will explain better, it means in some way moving to a prevention that is more tailored, not only based on, for example, age, but also considering multiple factors such as medical history, lifestyle, environment, and in some cases, biological and genetic information. The key idea is about reducing uncertainty and supporting better decisions. So we can act earlier, better, and where possible, avoid unnecessary tests or treatment. But going to the start, just some practical notes. We will have question and answers moments during the webinars, and please feel free to post questions in the chat at any time. We will also share the slides on our website after the session with all of you. And to make these more interactive, we'll run a few short Zoom polls. I'll launch them during the session and share the results with everyone. And we can start with a quick poll to understand who is in the room today. So, how familiar are you with personalized prevention? There is a question for you. Just a second. Okay, let us know. You are answering. Thank you. Some seconds more. Okay. So, as you can see, there is a good mix, but a lot of you is slightly or in some way familiar with this concept. So we can go into the deep of this webinar, and we can move to our first talk. It's my pleasure to introduce Dr. Sara Farina from Università Cattolica del Sacro Cuore, who will guide us throughout what personalized prevention is and how it differs from more traditional prevention, how it works in practice, and some real life examples with a brief introduction of the Prophet Project. Sarah is a medical doctor and she's completing her residency in hygiene and preventive medicine and public health. She's also a PhD candidate in public health with a strong focus on how genomics and personalized approaches can support prevention at the population level, especially throughout risk stratification and chronic disease prevention. Within the Prophet Project, Sarah is part of the team guiding and translating this topic into practical approaches and policy relevant insight. So, Sarah, thank you for being with us, and the floor is yours.
Thank you, Daniela. Good afternoon, everyone, and thank you for this introduction, for the invitation. And I'm very happy to be here today, especially because I'm seeing so many people participating in this very important event. I'm sharing my screen. Okay, I think you should see it. Just let me know.
Yes. Yes.
Okay. Okay. Good. So, as Daniela just said, I'm talking to you about personalized prevention. I know I don't have so much time to explain you everything about this topic because I would need days probably. So I will be brief and I'll try to make it as simple as possible. Okay. But just a brief, teaser of what I'm going to tell you. I will give you, let's say, something about the context, particularly about chronic diseases. I will give you some insights about why prevention is very important, even if Daniela already talked about it, especially for chronic diseases, what personalized prevention is. I will give you some example of personalized strategies in prevention, and I will talk to you about Prophet, this European project and initiative we are guiding in Europe. So when we talk about chronic diseases, we have to keep in mind that we're talking about something very, very important globally. These data are from the Global Burden of Disease Study, and they are from 2019, so a bit old data. But they show that in 2019, 74% of people were dying from non-communicable diseases, chronic diseases. So when we talk about chronic diseases, we talk about cardiovascular diseases, cancer, chronic respiratory conditions, digestive diseases, diabetes, neurological diseases, and so on. So the blue ones you can see in this slide. This is in contrast with the 14% people dying from infectious diseases, still, of course, important. and with the less than 1% people dying due to interpersonal violence. So this framework is just to show you a few years ago what was the important situation about personalized, about non-communicable diseases. Now we go to, now we go to 2023, okay? So right now, these are the very last data shared by the Global Burden of Disease Study. The data I just show you were global data. Now I talk about Europe. And here in this graph, you see the causes of death again. And again, still, the first three causes of death are cardiovascular diseases, cancer, and dementia. So chronic diseases. And you can see here that they cause millions of deaths in Europe. So this framework very easily shows us the importance of prevention. We still base our healthcare systems on the treatment paradigm, but we are understanding through this data that avoiding the occurrence of diseases is the most important action we should do. However, among EU countries, spending on preventive health in the last data we have from 2022, published from the Eurostat, by the Eurostat in 2025, spending on preventive health ranged between 1.2% and 7.9%. So you can see that the percentages are very low compared to how much our governments spend in terms of treatments. So we also talk about why chronic diseases are important to prevent and how we can prevent them. Here you can see what are the risk factors of chronic diseases. We have a multitude of risk factors, starting from lifestyle, going to the biological factors, including, of course, the DNA. And we know so that chronic diseases are multifactorial, are given by the sum of all these different risk factors. This is very important because it says us that we are all different. We all have a different DNA. We all have different habits. We all have different characteristics, even regarding our social environment we live in. So we all have different risk factors. And for this reason, we know that prevention already exists and plays a key role in public health, but it is not always equally effective for everyone. That's why we are making this transition from traditional prevention to personalized prevention. So in this slide, you can see some characteristics of traditional prevention compared to what personalized prevention aims to do. So basically, traditional prevention is okay. It gives a recommendation for everyone, the same recommendations for everyone. It's based mainly on some very well-known characteristics like age and sex, and it's based on a population approach. While personalized prevention aims to give personal adapted recommendations to the individuals, it's based on multiple factors. These factors, particularly on the DNA. And of course, it's still a population approach because we're still talking about public health. But let's say it gives a more individual risk approach. So knowing my personal risk of developing a specific disease in the course of our life, even when I'm young, even when I'm just born, okay? It's very important in order to do something to prevent these diseases. And I can do it. So what is the definition of personalized prevention? Personalized prevention aims to prevent the onset, progression, or recurrence of diseases. In our case, we are talking about chronic diseases, but we can do this also for infectious diseases. And it uses the normal traditional strategies we already have, but it aims to stratify these strategies basing on all the characteristics of the individuals. So behavioral characteristics, socioeconomic and cultural context of the individuals, but of course also biological information. And this should be done in a timely, effective, and equitable manner in order to maintain the best possible balance in lifetime trajectory. In this picture, you see the course of diseases, okay? So the three, let's say, stages. We have health status, we have the disease, and we have the complication. And these are the three main moments in which we can act to do prevention. So we have the primary, the secondary, and the tertiary prevention. We can do, as you can see in the first, in the top of the picture, you see we can do something to make general prevention, population prevention, to all people. But some of these people need more attention because they maybe have a different predisposition to develop diseases. So we can use biomarkers, lifestyle, environment, and so on to do personalized prevention, as you can see in the bottom of the picture, to particular groups of people. This doesn't mean that I'm not doing anything to the rest of population. I'm doing the same general strategies to the rest of population, but I'm giving more attention to the ones that have particular risk factors. So I give you some example of what personalized prevention can be and can do. I wanted to show you the three levels of prevention to give you a more broad idea of what we can do. And I highlight that not all these strategies are already implemented and fully adopted in clinical practice, but some of these are still under research, and we hope that in the future years they will be reality and will be used in clinical practice. So the first example is about primary prevention, and I wanted to bring to you this new, innovative, relatively new test that is the polygenic risk score. This provides us basically a score, a number that is given on a sum of different variants of our DNA. And it says us if we have a high risk to develop a specific disease in the course of our life. In this case, I'm bringing to you the example of cardiovascular diseases that are the ones that cause most of deaths in Europe and worldwide. But we also have different diseases like breast cancer, other cancers, other chronic diseases that we can predict using this test. And basically, if I use this test to people with some risk factors like, I don't know, smoking, high cholesterolemia, sedentary habits and stuff, I can give them an additional information also to convince them, maybe, probably, to change their lifestyle, which is the best way to prevent cardiovascular diseases. About secondary prevention, I brought you an example already implemented, which is the genetic testing of the gene BRCA1 and 2 that predispose to breast cancer, but also other cancers. These are well known, but for example, in Italy, this test was just implemented. I mean, so it's something not new, but for some countries new, let's say. And I can do this test to people with family history of breast cancer. And I can identify through this test people with higher individual breast cancer risk because they have the mutation in these genes. And in this way, I can adapt the screening strategies already existing. For example, the mammographic screening starts at 50, the age of 45 or 50 in some countries. In this case, I can start earlier, or I can do it not every 2 years, but every year, every 6 months. It depends on the entire risk of the individual. And then for tertiary prevention, we have still, for example, genetic approaches. One approach is the pharmacogenetic. It's still a genetic test that can tell me if how I can respond to a specific treatment, a medical treatment. It can predict the way the adverse events I will have using a specific treatment. This is very important when I do chemotherapy or I take drugs for neurological condition, because these drugs are famous, let's say, for their adverse event. In this case, I can adjust the dose or I can change the therapy using an equal effective treatment, but specific for the person I'm treating. And this is true for many conditions, for cancer, but also for cardiovascular diseases. So I'm in the same moment preventing adverse event, but also using the best drug to prevent the recurrence of the disease, for example, the infarction or cancer. So all the information I'm giving you have been collected within this project. Why I present to you the Prophet Project? Because of course it's sponsoring this event, because we work in this project together with Active Citizenship. So it's thanks to the European Commission and to the effort given to personalized prevention in the last years in Europe. This project is a fourth year right now. We are in the fourth year right now, and the last one. And it's a coordination and support action of the International Consortium for Personalized Medicine. And this project involves many, many partners all over Europe. They are private companies, patients organizations, they are research institutions, universities, and so on. And they all together, and together with also other stakeholders external to the project, we already developed and published two main documents: a strategic research and innovation agenda, SRIA, and the roadmap. And these two documents are strategic to guide countries in the definition and implementation of innovative, sustainable, and high-quality personalized strategies, particularly for chronic diseases. So I'm going to the end of my presentation. These two documents are shown in this slide. You can find them in our website, and if you want, I will send you the link to reach out the documents. The SRIA defined 10 main challenges you see in the middle of the slide. They touch very different topics, including the importance of prevention, the importance of sharing data, the involvement of citizens, of professionals, the equity, the ethical, legal, and social issues, regulatory aspects, and so on. And the roadmap takes these 10 challenges and translates them in very concrete actions, identifying the main actors involved and the timelines. So it's a very guiding document for institutions and governments. So the Prophet Project provides a structured guide to support European healthcare systems in implementing personalized prevention. So in conclusion, chronic diseases are a major challenge for our societies. However, our countries are not investing enough money on prevention. That's why personalized prevention is important, not only because it can help adapt prevention to each person, but because it's more effective and cost effective. And this is something we are still trying to demonstrate through research. And fortunately, in Europe, we have different initiatives, including Prophet, that are supporting this transition toward effective, equitable, and sustainable personalized prevention. So we have to keep in mind, as I said a few slides ago, that personalized prevention does not replace population prevention, but it can complement it. Thank you very much for your attention.
Thank you very much, Sarah. Very clear. Before we move on, please, if you have any questions to Sarah, as said, you can write in the chat. But if I can ask something about something that you cited yet, but how much of personalized prevention is already a reality today. Can you give us another insight about that?
Thank you, Daniela. Yes, let's say personalized prevention is something we are talking about since 20 years ago. But it's still not fully part of our healthcare systems. If it's not prevention fully part of our healthcare systems, how can we pretend personalized prevention to be included in our clinical practice? Now we can, think about our general practitioners suggesting us to do genetic tests or other personalized approaches. So some approaches are already part of our clinical practice. I gave you the example of the BRCA mutation. It's something well known because we already have research about it. We know very well the risk given to people with those mutations. We know that it's very high. So we are sure that in intervening on those people is effective and cost effective and important. And it's something that it's interest of our decision makers. Some other strategies are not part of our healthcare systems. The polygenic risk score I showed you is something still under research. For example, here in Rome, we are doing so many pilots in order to demonstrate or understand if doing this test is effective to predict the risk of disease. We know that it can predict the risk, but we would like to know, okay, now that we do this test, what can we do after having the risk framework of people? We need to do something to prevent, not only to predict. And this is the step after. So we are still working on this, and we hope in the future we will have some concrete example, more concrete example. Of course, we have also other examples that are the ones without the genetic included, but with other biomarkers or based on the lifestyle or the, I don't know, for example, for people who smoke cigarettes, we have some approaches to have, a more intense follow-up for lung cancer. But studying lifestyle is, of course, harder than studying the genome or the genes of people. So just to conclude this answer, what can we do to make personalized prevention reality? We need a very strong effort by decision makers, by healthcare personnel that don't have enough training to know how to communicate personal risk, how to manage people at high risk. We need research. Of course, we need money and funds because without money, we cannot guarantee that all people can access to this kind of tests, this kind of strategies. So we are putting efforts in this, but it's still challenging, let's say.
Thank you very much. So now we move to something that really helps bring this concept to life. So it's a first-person story, and we are very happy to welcome Tamara Milagre, founder of Evita, who will share a real-life perspective on what it means to discover hereditary cancer risk and how informed choices, support, and prevention can make a concrete difference for individuals and families. From that experience, she founded Evita, an organization dedicated to supporting people and families affected by hereditary cancer, offering information, support, and a community. Tamara, thank you so much for joining us, and please go ahead.
Thank you so much for your kind introduction. I'm very happy to be here today because personalized prevention is very close to my heart and to my genes. I'm myself a BRCA1 carrier. I'm a daughter of two BRCA1 carrier parents, so mother and father, they both were carriers. They both died of hereditary cancer. My whole family at this generation died of hereditary cancer. And I was lucky to have the knowledge to act on it and prevent the disease. And that was the motivation to found Evita and to save life of other people that are not aware of genetic predisposition, because as long as we already know the BRCA genes, for example, we know them since 33 years, 32 years. People are still dying from related cancers, which is a clear sign that we are failing cancer prevention regarding hereditary cancer syndromes. So I really would like to start to talk to you about what we can do, because it's clearly actionable. I will tell you about the unmet needs, a solution we found, how we can help, how you can help, and also the take-home message. Fun fact, Evita is since 2011. It was globally the first patient association supporting families affected by all hereditary cancer syndromes. So we start with the general information. Hereditary cancer is a consequence of a genetic predisposition due to an inherited pathogenic germline variant, commonly known as mutation. And in rare cases, it starts de novo with the newborn, so you won't find an affected parent. This is quite often the case in childhood cancer. If we look for Li-Fraumeni syndrome, has a very high de novo incidence, up to 25%. So the genetic variant carrier has an elevated risk to develop early onset cancer in a group of organs. So, for example, a BRCA2 carrier has an increased risk for breast, ovarian, prostate, and pancreatic cancer. The other way around, if you diagnose a breast cancer patient, there may be involved a group of genes. So it's not only BRCA. We know nowadays there PALB2 is quite high penetrant still, and other genes are involved. So there are big panels you can use when you have an early onset breast cancer patient. So literature tells us since many years, 5 to 10% are hereditary cancers. Not sure about that, because we only identify 20% of genetic variant carriers. So we are missing out on 80% of the carriers for some reason. And over half of hereditary cancer patients do not meet testing criteria. The family history may not be clear because the family is small, because the family members do not really communicate with each other. And for other reasons, they also don't undergo genetic testing, because oncologists, they want to know information that is important for their treatment decisions. So if they have a stomach cancer patient, they won't look up for the CDH1 gene, which is related to stomach cancer, but also to lobular breast cancer. They just want, if there is a young breast cancer patient, they want to know if there is a BRCA mutation, because nowadays we have commercialized target therapy with PARP inhibitors for BRCA-related cancers, which is quite effective. So if we look at Portugal, our numbers tell us we have a cancer incidence of 70,000 new cases per year. If we do the math, we come to 7,000 hereditary cancer patients each year. And as we talk during the day, we will diagnose 19 people with hereditary cancer. In Portugal, if we look at Europe, we have almost 500,000 of hereditary cancer patients each year, and 1,233 cancer patients with hereditary cancer every day in Europe. I mean, those are impressive numbers. I don't know why people continue to talk about that's very rare, the hereditary cancer stuff, because it isn't. 10% of a big number is still a big number. So the three most prevalent cancers are potentially involved within the two most frequent hereditary cancer syndromes, which is hereditary breast ovarian prostate cancer syndrome and Lynch syndrome. And also lung cancer was recently related to hereditary cancer syndromes. Stomach cancer is also maybe linked to hereditary cancer syndrome. So if the carrier or even the healthcare professionals, if they are not aware of the genetic predisposition, first symptoms may be disregarded, which delays the diagnosis. That is how it started, Evita, because I, as a nurse, took care of a young cancer patient, 27 years old, mastectomy at the 29th week of pregnancy in our hospital. I took care of her. I looked at her. I thought, what happened here? She's 27. I've never heard something like that. She got breast cancer. Why is that the case? And why did nobody give attention to her first symptoms? Because she complained with her doctor. She felt the lump early in her pregnancy, and he just disregarded it totally and said, nobody at your age has breast cancer. And that ignorance cost her life 2 years later. So due to the early onset of hereditary cancer, so it shows up before 50 years of age, during the peak of fertility and productivity in most cases, and quite often late stage diagnosis. Again, nobody would tell that such a young person could get colorectal cancer at 21 years of age, for example. It shows really very early. So the late stage diagnoses are easily explained. Not even the self pays enough attention to the first symptoms. Hereditary cancer, no doubt at all, represents a very high socioeconomic burden. And we will have first evidence on those calculations within the European Project Preventable Final Conference, 22 to 24th of April in Porto, in Portugal. We will have, for the first time ever, evidence on the socioeconomic burden of hereditary cancer syndromes. This will be very useful to convince decision makers because they want numbers. So the very low genetic literacy in civil and even medical society blocks access to genetic counseling and genetic testing. I mean, I was a healthcare professional myself. I had no idea at all when I met this young cancer patient. But anybody outside oncology or medical genetics is not truly aware of patterns that would identify hereditary cancer syndromes. So the complexity of all the syndromes, again, who would tell that this pancreatic cancer would be related to prostate cancer of the uncle, something like that? Nobody would tell, but it can be the case. And the information is quite dispersed regarding hereditary cancer syndrome. It's a family matter. It's not an individual disease. It affects the whole family, and the impact on mental health is totally underserved nowadays. We have unacceptable waiting times for genetic counseling, testing, and also for risk-reducing surgeries. And we could actually practice precision prevention and primary prevention if we would identify more and better genetic variant carriers before they get sick, and they could advance with their risk-reducing surgeries. And they could also think about pre-implantation genetic diagnosis and prevent totally to pass down the mutation to the offspring. So there is also inequity in treatment access, and we have, as already heard by the great presentation of Dr. Sarah Farina, there is a lack of strategy and very low budget on prevention and early detection in our systems. We are all focused on the remedy, while it's much more expensive than the focus on prevention. If we prevent disease, we can save a lot of money. The recently updated European Code Against Cancer continues to overlook the highest risk factor of all, because there are syndromes that guarantee that you get your colorectal cancer. For example, if we look at the familial polyposis cancer syndrome, and this highest risk factor is still overlooked by the code. I don't understand why, because that would be an excellent opportunity to raise awareness for genetic predisposition, which is so unknown by healthcare professionals outside oncology. So back to Portugal, we have a Portuguese founder mutation in the BRCA2 gene. It's an INSALU. It's very difficult to identify. If you need to look up it, you need to look it up proactively because it needs a specific sequence method. So we asked our board at the European Reference Network, GenTouris, for genetic tumor risk syndromes, to release a note on this specific founder mutation. So any patient with Portuguese ancestry would do also this specific founder mutation, because we got contacted by women from France, for example. By the way, Portugal is European champion in emigration. 20% of the population is emigrated. And France is one of the countries, many others also, the mutation is all over in Brazil, for example. So those women contacted us from France, they had a very typical BRCA family and personal history of cancer. The result came back negative, and they contacted us. And now, what are we going to do? We have this many cases, but we have no mutation identified. We called attention. They should check with their doctor if they have done the Portuguese founder mutation, and it came out they didn't. So they did it afterwards, and were afterwards identified as genetic variant carriers of this pathogenic founder mutation variant. So in Portugal, it's related to 30% of all BRCA-related cancers, and even 60% to all BRCA2 related cancers. So this is a lot of cancer in Portugal that is related to this founder mutation. And our proposal of Evita is, why don't we do a populational screening for females from 25 years on? At 25, they start their personalized screening journey. So disregarding personal or family history of cancer, again, family history is not always present. I have it in my own family. My father had a lot of siblings, many sisters, and the family history was devastating. So all my aunts had breast and ovarian cancer. My paternal grandmother died of ovarian cancer. My father of prostate cancer. But on my mother's side, it was only her with the first breast cancer at 44 and a second contralateral, multifocal, triple negative, like it's in the book for BRCA1 mutation cancer. 30 years later, when that happened, I asked the doctors to do genetic testing for my mother, because of a brother of mine that was negative for the paternal mutation, is father of 4 daughters, and then he tested, in fact, positive for the maternal mutation. So again, do not focus only on family history of cancer, because it may not be present. So we need to find other approaches. And if we do a populational screening for a founder mutation in a founder population, we will get clear yes or no. There won't be variants of unknown significance. We will have clear answers regarding those founder mutations. And we also do not have any data on hereditary cancer in Portugal. Being a European champion in BRCA1 cancers in Europe, we do not have a single hereditary cancer in our national cancer registry. So that is for sure because of political will and investment. We do not have those registries because, yeah, we need them. We cannot define any strategy without numbers. Quality data is the fundamental basis for a good strategy. Again, there is a lack of patient and public involvement and engagement in health technology assessment and research. So national and European policies. In Portugal, our General Direction of Health invited a specific working group on hereditary cancer within the National Cancer Plan. I'm fortunately a member of this working group, and while it's focused on early detection, we are also challenged to improve the approach to hereditary cancer prevention, which is our thing. You need to know our name, Evita, is the Portuguese word for avoid. So we want to avoid cancer. We want to prevent hereditary cancer, which is doable in many cases. And in Europe, on the European level, for the very first time, we had last year the first call for early detection on heritable cancers. I want to believe that Evita has done its share. We sent our input to every member of the European Cancer Mission regarding prevention and early detection of hereditary cancer, because we are still failing. I mean, we go still to funerals of those young women that die of hereditary breast or ovarian cancer, leaving their minor children orphans at home. I mean, this is totally absurd. But in Europe, we have already 3 European projects that are focused on early detection of heritable cancers. The SHIELD is regarding pancreatic cancer, DISARM, ovarian cancer, and PREDI-LYNCH, as the name says, Lynch-related cancers. So this early scan cluster is very important for future policies of prevention and early detection for hereditary cancer in Europe. By the way, Evita is a partner in DISARM and PREDI-LYNCH project. And of course, we are involved in our European reference network, Centuris. Within the EPEC Council, we represent carriers on the European level. So our solution, as we did not see anything move top down, we started to think about an initiative bottom up, which is now called Evita Platform. 7 years later, it's a citizen initiative based on unmet needs that we identified during our 15 years of activity. We have 3 user profiles for the general citizen, whoever is interested on the topic, for healthcare professionals and researchers. We provide a familial risk awareness tool, familial cancer risk awareness tool that generates an immediate result. So it's a short questionnaire that is based on our national recommendations of our program, Genetics and Oncology, within the Portuguese Society of Oncology. I'm also a founder member of that working group. I mean, as you see, I'm really motivated because I lost my whole family. Now we have the chance in my generation to do something about it. And we really need to improve the choice for the next generation, because cutting off healthy body parts is also not an ideal solution for us, right? So we do not diagnose anything. That's very important to mention. We are a nonprofit patient association. We just try to funnel a little bit down who would be the people that would benefit from genetic counseling, which we want to offer, and it's already technologically foreseen. We want to offer genetic counseling and psychological counseling. Mental health goes hand in hand with cancer diagnosis and threat. We want to offer that via telemedicine inside Evita Platform in a safe space. So Evita Platform is a GDPR compliant digital platform with high standard technology for everyone. The concept is that the user is in charge of of his health and his data. That's the concept. So it's not a registry from third parties that you have to feed and they want to use your data for this and that. It's for the user. It's thought for the user. And of course, they are invited to participate in research with their anonymized data, but nothing happens without an informed consent. And it's all a safe space. We also help with the health literacy, offering lay summaries for research articles, newsletters, and webinars. We inform regarding clinical trials, recruiting in Europe, and the clinical area where you have a secure space for uploading your entire clinical process in a centralized manner to overcome the barrier of the lack of interoperability. You know, you have hospitals where the first floor does not communicate with the second floor, which is totally absurd, but it happens. So we actually repeat exams and analysis and so on, and blood work. We repeat those things because we do not have our information centralized. And then we are treated in 4 different hospitals, and then we go on holidays and we end up at the emergency because we fell there and that, and we do not have our stuff with us, and we need to repeat the analysis and the exams and the x-ray and so on and so forth. And there's also a clinical diary with possibility of granting access to the authorized oncologist, so he knows what's going on and can prepare better for the next consultation, which is telemonitoring. We know that our healthcare professionals have more and more burden of patients and less time within the proper consultation to talk to them. We have a digital agenda there to book the appointments for telemedicine of genetic counseling and psychological counseling. And again, we have another tool that is called My Questionnaires, which is precisely to perform any questionnaire in any language about any topic to help research and health technology assessment. And we have all this stuff available in an app. So the healthcare professionals, as I said, oncologists, genetics, psychologists, they have their specific area and their specific entry. And the researcher also has its own profile to perform questionnaires, and also can have a look at a reservoir with previous research and reach out to those to identify new or better questions for his prompts frames and producing real-world data and real-world evidence. Very boring slide, but just so you know, we took care that we are compliant with GDPR, of course. And we had a lot of support in a private finance consortium, because in Portugal, patient associations do not receive any support from government. So we need to go out and sell pink dolls to produce our leaflets, or we are involved in research projects and have our team financed by that. So how you can help? Grow the flow, dissemination and recommendation of Evita platform anywhere you go. You can use it by yourself. Even if you're healthcare professionals, to get access to the My Risk questionnaire, you need to register at the general Evita user, which is the only way to access the questionnaire. But you can sit next to your patient and do the question. If you are a general practitioner, and you are not full of genetic literature, you may be grateful to have this questionnaire. We have already many GPs using our questionnaire to understand if this patient would benefit from genetic counseling, so it's easier for them to decide the referral to genetic counseling. And if we look at our first data, we have now 4,345 registries on Evita platform. Actually, 75% of our users decided to take the My Risk questionnaire. And not surprisingly, because people that underwent the questionnaire, they were already thinking about their risk, and they already tried to get access to genetic counseling and testing, which was blocked by lack of literacy of the healthcare professional. I mean, we hear stuff like, why do you want to know that you already had cancer? Now enjoy your life. And so we have really incredible comments on informed patients that would like to learn about their genetic predisposition. So 1,384 left their demographic data in my profile, which are important for target population selection for research. Not surprisingly, most of them are women. We are different. Men and women are different. There's a book out called "Men Are from Mars and Women from Venus," something like that. That's so true for many areas in life, but also communication in health-related issues is very difficult to men. They are kind of afraid to learn about this kind of stuff. And if we talk about a higher risk for cancer that they may have passed down to their daughters or sons, that's also not a very comfortable information for them. We have 321 cancer patients, and of course, most of them are breast cancer patients. So take home message: prevention of waste and disease are fundamental pillars for the sustainability of the system. So what are we waiting for? Hereditary cancer syndromes are so actionable. I mean, look at me. I'm talking to you. If I hadn't known before, I probably would not sit here today. That's a fact regarding my family history of cancer. So we need to identify more and better genetic variant carriers. We should use available digital tools like the Vita platform, for example, to facilitate, because we do not have all the genetic literacy. We should organize the ideal pathways within the systems. We will look at the preventable project outcomes. So we learn how much money we are spending on remedy of all those cancer patients we could have prevented before. And of course, we would have many more healthier and happier families. We are in touch with them every day. We see faces, real persons. We talk to them in person and virtually. And we see parents die and children left behind. It's dramatic, it's cruel, and it's difficult to get there if you are not in the field. But I really hope decision makers will wake up for this very avoidable expense we have in our system. We can truly save many more lives together. And with this, I thank you very much for your attention. And if you have any further, more detailed questions regarding Evita platform, reach out to our Evita platform manager, Tatjana. She's very keen to answer any question. Thank you so much.
Thank you very much, Tamara, for such a powerful perspective. We can now open the floor for question and answer with both speakers, if any has said right in the chat. In the meantime, you write or raise your hand. I have a question for to both of you. Regarding emotions, because what happens emotionally when people learn they are at higher risk of a disease? I'm thinking there is a risk that this information could cause, of course, anxiety, and how can healthcare professionals and patients association support patients and family in understanding and coping with this information?
Yeah, I can start.
Thank you.
People are individuals, and everybody has different reactions to this kind of information. So there is no one fits all strategy to approach this type of predisposition, if it's cardio related or cancer related or whatever. There is no one fits at all. The fact is that not everybody wants to know about their risk, but to to give them their own decision, they need to understand first what they do not want to know, which is also quite tricky. So I can tell you that for me, it was a very valuable information because it explained me why everybody died of cancer in my family. It woke me up for my own family history of cancer and gave me the possibility to be proactive and do something against it, to prevent cancer. So I underwent all the preventive surgeries, which again, it's not a very smooth surgery. They are very invasive and brutally complex surgeries and painful, and not always everything is fantastic, and it's not a cosmetic surgery. People think, yeah, you get your boob job, and so not at all. It's totally different surgery, and it's important that people understand that this information is a good thing. So that was also the reason why I decided to give hereditary cancer a face, because supposedly it's a secret that you have a genetic variant because of your professional situation. Your boss should not know that you have a predisposition to disease because you have to go to hospital appointments, to prevention, and so on and so forth. You will do surgeries and so on. So it can harm you, this information, if third parties know about this condition. But we have laws that protect us from this question. So an insurance company cannot ask any questions regarding your genetic conditions. So you are not forced to talk about this genetic predisposition. If you want to buy a house or a flat, you need to talk to insurance and make an insurance company. They cannot ask this kind of questions, but it's still in a gray area. Nobody really knows how to handle it. But here in Evita, the main goal was always to transmit to everybody, hey, people, listen up. If you have cancer in your family, it may have a genetic predisposition at the basis, but that's very important to know because you can do something about it. You can even prevent to pass it down to your children. If you do not do anything about it, it's still there and it will manifest in some way. So it takes courage to learn about it, but you are not alone. We are here. We have been there. We are there. We can guide you through this journey. So the contact with patient associations, and if you're healthcare professionals, please refer everybody to patient associations, because there is no doctor appointment that can give you this sense of belonging to a group of people that is going through absolutely the same stuff, and they are still here, and look, they are looking good, they are healthy, they are cured from their cancer, whatever. They act on it, and they prevented the worst possible outcome with this early death due to metastatic disease. We can prevent at least late stage diagnosis. Prevention is not always possible, as we know. There are organs you cannot take out preventive, but you can look at them and you can prevent very early starting cancer, and with minimal invasive interventions, you may cure the disease. So that's a good thing to know it. It's not a bad thing. It's a good thing.
Very, very useful. Thank you. Sarah, would you like to say something from your perspective?
Thank you
Then we
very
have
much.
some questions.
It's not easy to answer after Dr. Tamara's song, because her speech was so powerful, and for sure she's bringing a personal experience. So I can tell you something we are just doing in our institution in Catholic University in Rome. And first, I agree with everything you, Tamara, just said. I think one of the main pillars of an effective personalized prevention is communication. So communication should be through the media. Communication should be from the doctors to patients, to citizens, to families. As a medical doctor, I can confirm what Tamara said, that during medical school, nobody teaches us how to communicate with patients. We're talking about personalized risk, genetic. Okay, this is even more. Doctors don't know how to communicate the most simple, information to the patients they have, and they don't know anything about data, about genetics, about predisposition. So first we need training for all the personals, and then of course what Tamara said about the sense of community that all patients, but citizens in general should have when we talk about prevention, when we talk about the benefit of knowing what your personal risk is in your life. There are benefits, and we should leverage the benefits. Of course, about the mental impact of communicating, for example, the polygenic risk score I told you. We are studying here if polygenic risk score is, if knowing personal polygenic risk score, and if it's high risk, we are studying if people, for example, change their behaviors, if they quit smoking, if they lose weight, and we are also studying the literature about this, about how communicating polygenic risk score can impact in well and in the good and bad habits. And the results are not so good because we know that people don't change their behaviors. I mean, even if you, you make leverage on their risk, it depends on their personal situation in the moment they're living in their life. You cannot ask people quit smoking if they are facing a divorce, if they have economic issues. You can't ask this. You can just communicate the risk and leave people alone. So this is what we are collecting from literature and from our studies. But fortunately, when it's when we talk about, for example, cancer prevention, follow-up screening, when we talk about also primary prevention of cancer, not about lifestyle, but about I don't know, the preventive surgery, the genetic test in families. We know that the mental impact is not bad, not always. Of course, I'm talking about means. Okay, I'm talking about literature, statistics, and we know that the impact is good. The anxiety is not too high, and it's instrumental to have a good follow-up and surveillance in order to prevent and have benefits. So this is what literature says. Here in Catholic University, we are doing a study, for example, using an algorithm that includes polygenic risk score, or the panel for breast cancer, and all the risk factors for breast cancer. This is the CAN risk score. And we are collecting this data about how women feel about after knowing their risk. We are also collecting if they want to be included in the study, and when they say no, we ask why. If they are, I don't know, if they don't want to know their risk, why they don't want to know their personal risk, especially because we are including in this study, this particular study, women with already known risk factors like familiarity, other cancer history, family history, and so on. So they are women with particular attention by the healthcare system, by our hospital, and sometimes they don't know, they don't want to know their risk, even if they are already at risk. So as Tamara said, it's very individual question.
Yes, thank you very much, both for your answer. We have some questions in the chat for both of you. Just a second. The first one is how much does personalized prevention rely on artificial intelligence? Do we have ideas about limits of the current models used? I don't know if Sarah knows something about
Yeah.
that.
I'm not an
Okay.
expert of AI, but thank you for the question. I think that AI is fundamental for everything right now because we are not able to work anymore without AI. In personalized prevention, particularly when we talk about omics sciences, so we talk about a very large number of data, and of course we need AI to analyze them all together in order to create scores that include all the different characteristics of the individual, all the genome, all the proteome, all the radiomic. For example, in imaging diagnostics is very important AI. So of course is fundamental. I think that as we said about personalized prevention in general, for AI, I think that the concept of training of professionals is even more important because we don't have the instruments to know how to use AI. So we always need people very specialized in how to use AI, and they often are not healthcare professionals. So it's very hard to combine the two careers. And also AI has several limitations regarding the bias that it includes when we do analysis, because of course it's influenced by what it has already received by other researchers, by scientific literature, and the bias can be about gender, about race, about other characteristics. So we still need to work on how AI can support us in, especially in doing analysis of and giving the final result of what's your personal risk.
Yeah, I can tell you quickly regarding Evita, we are thinking about a chatbot to help identify better the people that would need genetic counseling, which is the first step for personalized prevention in hereditary cancer. Because again, we have so many syndromes. There are over 100 known hereditary cancer syndromes nowadays, and we will discover every week another one. And AI as a complementary tool, and also it's obligational. I mean, nothing will happen without AI in the future. We are in the middle of the AI revolution. Of course, it's much easier if you feed your chatbot with current guidelines and it just spits you out in 2 seconds, which may be eventually a syndrome in question when you describe the clinical situation of the patient, something like that. So I see a huge advantage in the use of AI, but we need to use it very carefully with quality data because your answers you get are as good as your questions are. So you need to be very careful. But there is definitely an important field for the identification of potential variant carriers with AI.
Amiga do João. Adesso non si sente più, perché non lo sento più?
Okay, sorry, someone with the audio on. And okay, thank you, Tamara. And there is another comment or question that you mentioned yet because it's regarding the mental impact of these inherited diseases. So regarding the mental impact, should genetic counseling and mental health support not be a matter of course when a diagnosis is given? A holistic approach to patients is needed and comorbidities considered too. but I think it's something that you mention a lot and you give the right importance. There is a question I can understand more in deep, but is there the possibility to get a false advice from Evita?
Yeah,
I don't know if
that no, that's
okay.
an important question. That's an
Okay.
important question, no doubt about that. I can assure you we don't want to take any risk. What we are doing with our 10-question questionnaire is we simply transform the indication for genetic counseling into questions. So if you answer one question with yes, we already advise you to make an appointment with a genetic counselor. The questions are very general. It's typical for cancer syndromes. One question, for example, is, do you have a family member with more than one primary cancer? So my aunt was diagnosed with breast cancer at 42. At 46, she was diagnosed with ovarian cancer, and then she died from ovarian cancer. That would be already a yes, and that would be already an advice to have genetic counseling. So those questions are bullet points of our national recommendations, and I alert those recommendations can differ from country to country. It's not always the same. That would be adopted to the respective country. But in our country, this is a reason to refer somebody to genetic counseling. So as soon as somebody answers, I don't know, and everything else is no, we invite them to investigate further their family history, because like this, we cannot give a result. Yeah. If they have a I don't know, it can be a yes or a no. If it's a yes, we advise to have genetic counseling. If it's a no, based on the answers given, there is no apparent higher risk. So we are on the safe side with that, with confirmed recommendations from our experts. Yeah.
Thank you very much. And there is another comment, but it's just that to yes, not lose the human element when using artificial intelligence, of course. Okay, a lot of
Can I just
compliments.
comment on
Yeah.
that? Can I just comment on that? Because that's something that I hear a lot, mainly from my colleagues, the patient representatives, and so on and so forth. And it's true, we cannot lose the human factor. But who is using the AI is the healthcare professional. So the healthcare professional is still in person and alive in your front, using AI tools to help you better and has this personalized. It's not thought to substitute any healthcare professional. Again, it's complementary to the healthcare professionals' activities. And it will be, yeah, it accelerates simply a lot of knowledge that we would gain anyways, but we would need to invest weeks or months to get there. Yeah, it's a good thing. So we are not responsible for bad people that abuse AI. I think in the healthcare sector, it's not the case.
We hope, of course. So, thank you very much. And we are coming to the end of our webinar. And first of all, a big thank you again to Sara Farina and Tamara Milagre, and to all of you for your participation and thoughtful questions. Summarizing today in three simple messages: personalized prevention can help us act earlier and more effectively, using better information to tailor prevention and care. And for it to truly work for everyone, it must be understandable, first of all, and accessible, and it should not create new inequalities. And third, Citizens are not passive recipients. They need to be informed, protected, and involved, including when it comes to data, privacy, and trust. Finally, a quick look ahead. In the coming months, we will continue this conversation. We can already share that the next European Patients' Rights Day, the 20th edition, will focus on profit and personalized prevention, and it will take place on 12th of May in Brussels. And registration will open soon, and we will keep you updated on how to participate and contribute. And as promised, we will send you the slides after the webinar, and when available, the recording as well. And thank you again, and have a wonderful afternoon.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.